manuscript is a unique experience that we have here at the Mayo Clinic, the nation's only experience with implanting a product called the human acellular vessel as a biologic conduit for bypass surgery in patients with critical limb-threatening ischemia, or CLTI. My name is Todd Rasmussen. I am a professor of surgery at Mayo Clinic, vice chair of education in the Department of Surgery, and a senior associate consultant in the Division of Vascular Surgery here in Rochester. And I'm going to defer now to my colleague, Dr. Sen, who can introduce herself.
Hello, everyone. I'm Indrani Sen. I'm an assistant professor and a senior associate consultant in vascular surgery at the Mayo Clinic Health Systems in Eau Claire. So this paper is outlining the outcomes of arterial bypass with the human acellular vessel performed for critical limb ischemia under the FDA Expanded Access Program. And again, this will appear in the Mayo Clinic Proceedings.
The human acellular vessel, often referred to as the HAV, is just that. It's an off-the-shelf biologic conduit grown using regenerative medicine technology from human vascular smooth muscle cells. The HAV is a product that the FDA, the U.S. Food and Drug Administration, has allowed us here at Mayo Clinic to use as part of their expanded access program. They've issued me and my colleagues an expanded access IND, investigational new drug, for us to implant this vessel in a unique population of patients with few alternative limb salvage options. And the results of our study that will appear in the Mayo Clinic Proceedings, I think, will guide further regulatory deliberations of this product. It's not yet FDA approved. And I think it also, the results of our studies will give, I think, some unique insights into how this type of regenerative medicine technology can be used for these patients with critical lower extremity ischemia who have no autologous bypass options. So I'm going to defer now to my colleague, Dr. Sen, who can tell us a little bit more about the article.
The HAV is a bioengineered vascular conduit, as Dr. Rasmussen just mentioned, and this is designed by Humacyte. It is manufactured as of now as a 6 millimeter conduit, which is 40 centimeters long, using human smooth muscle donor cells. The product is under regulatory study. So this study from May 2019 to April 2021 included 14 patients in whom this HAV graft was implanted as part of a single-use investigational new drug EAP issued by the FDA for each of these patients. This is considered a drug as of now, hence this compassionate use protocol. There were 12 males. The mean age was around 62 years, and this was performed at 3 centers in the US. What we analyzed was the technical and clinical outcomes, and this was essentially a safety study in this group of patients who are essentially non-reconstructible otherwise. They had no other available venous conduits, and their disease pattern was too severe to consider use of a prosthetic graft. A single HAV was implanted in 9 of these patients, and 5 patients required 2 grafts sewn together as a composite. Technical success was 100%. All of the patients came out of the OR with a happy surgeon. The median follow-up was 12 months, range of 1 to 41 months, and follow-up was complete for this entire cohort up to the time of publication. So this is extremely, I would say it's extremely strong data. Primary and secondary patency were 72% and 81% at 12 months. Amputation-free survival was 93% at 6 months and 77% at 12 months. So these grafts did do well with secondary intervention, which were both open and endovascular procedures. All patients with a patent HAV experienced clinical improvement, and there were no infections or adverse events that could be attributed to the HAV itself. And the limb salvage was extremely good in comparison to other historic reports, which report amputation rates as high as 80 or 90%. So amputation-free survival of 80% is almost unheard of. So this kind of brings up the very important question that how is this relevant to clinical practice? And I'm going to ask Dr. Rasmussen to tell us a little bit more about that.
That's an excellent summary, Dr. Sen. And how do these findings of the study, how they relate to clinical practice? I think a very unique part about this experience in the study is the origins of the human acellular vessel and its application to human use as a vascular conduit. And what the listeners or readers may not know is that much of the interest in this biologic conduit, blood vessel replacement, basically, came from the U.S. military, the military's health system, and its combat casualty care research program. Much of the interest in clinical practice actually is in the area of vascular injury and trauma. As Dr. Sen mentioned, currently the human acellular vessel or HAV development program looks at a one size fits most. It's a 6 millimeter diameter vessel that's grown 40 centimeters in length. Again, it's not a size that fits or corresponds to all blood vessels, but to many, whether those are blood vessels that have been injured during trauma, civilian trauma or military related trauma, or it's a blood vessel size that allows us to do bypass operations in many patients with peripheral arterial disease or critical limb threatening ischemia. So I think the clinical practice implications are broad, and maybe Dr. Sen, you could talk a little bit about what these findings mean for civilian patients.
As we know from historic data, almost 60 to 80% of patients with peripheral arterial disease who need bypasses may not have available long segment saphenous veins. And the BEST CLI was one of the recent studies which kind of looked into this. And eventually they too concluded that for those with critical limb ischemia or critical limb threatening ischemia, a bypass with autogenous vein provides the best results. Now, if they don't, then whatever else we do seems to be sort of equivalent. It's still a matter of debate in that this kind of implies that we should shy away from endovascular treatment and do a little more bypasses. And that's, quite contrary to current practice. So it's still under debate. Obviously, there is need for an autologous conduit. Now, we know that nothing really can match the great saphenous vein or, what a patient is born with. But there has really not been any advance in the field of autologous vascular conduits parallel to what we have seen for, say, Dacron or PTFE or heparin-bonded grafts. Prosthetic grafts have seen a lot of research, but not autologous grafts. And we could say that, we have xenografts, or cryografts, but especially in patients who need what we call far-away bypasses, so femoral to tibial or, long bypasses. We know that these two do not perform as well as great saphenous vein. So for sure, there is a role for something more, and maybe HAV is that something more. But that, I think, needs more research. So maybe to finish the discussion of Dr. Rasmussen, next steps, how is this going to go forward?
Yeah, it's a great question. And I think we're very excited here at Mayo Clinic, Rochester, and within the health system to have the opportunity to really be one of the nation's hubs when it relates to investigating this new blood vessel conduit. So I think the next steps in the near term, I think we will complete the investigational new drug IND study here at Mayo Clinic that we are fortunate to collaborate with the FDA on. We'll complete that study. I think that working closely with industry partners and industry scientists, we are likely to then need to do comparisons between the human acellular vessel and other standards of care. So you've mentioned single segment saphenous vein or great saphenous vein. The questions will be how does the human acellular vessel compare to saphenous vein? The hope would be that if the product performs well in these comparator studies, that it could attain approval from the FDA and then be more broadly available in clinical practice.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.